Dr. Ciccarone's presentation about the fourth wave of the opioid epidemic. And so what our attendees can do is you can type in your questions during the doctor's presentation, and then at the end of his presentation, we'll ask him questions from the audience, and then we'll introduce the panelists, and well, rather the panelists will introduce themselves and talk about their work. And then after that, we'll have hopefully what's a really kind of free-flowing conversation. Some of the things I want to make sure that we definitely hit upon, that I always want to hit on when we have conversations around substance use and prevention and interventions in particular, are make sure that we talk about race and equity and gender-based violence and protecting victims. I think those are really important themes that we always, want to make sure that we hit on. Before we get started, I do want to give a shout out to some of our special guests that we have that have signed up. We had 170 people who registered for this Zoom, and we had 347 responses on Facebook. And we're also recording this, and it's my hope that as many people as possible in Berkshire County will have an opportunity to view this discussion, because I saw Dr. Ciccarone at the RISE Massachusetts conference in Boston on February 24th, and the Mary Lou Sutters, who's our Secretary of Human Health or something like that in Massachusetts, had to leave the conference to go convince reporters that COVID was, they were overreacting about COVID. Do you remember that, Doctor?
I do.
I remember that. So, but I was really moved. I mean, this is a riveting presentation, and the fire alarm or something is going off in my office. Just if you can hear it, I'm hopefully the building is not burning down. But this is a riveting conversation. I've been to other presentations put on by the Department of Justice, where the DEA and the FBI talk about the flow of drugs into the country, what we can expect to see in New England. They are telling us we can expect to see more fentanyl, we should expect to see more stimulants, and they're telling local municipalities, we need to be ready for this. And I'm a lawyer. I'm not exactly sure how to make my community ready for more stimulants and more fentanyl in the community. So it was really empowering to hear from Dr. Ciccarone. So I wanted to make sure that as many people in our community as possible would have access. So Dr. Ciccarone is a board certified clinician in family medicine and addiction medicine in his position as professor of family and community medicine at University of California in San Francisco. He has been principal or co-investigator on numerous NIH-sponsored public health research projects, including his current heroin in transition study. He is a recognized international scholar on the medical, public health, and public policy dimensions of substance use, risk, and consequences. He is associate editor for the International Journal of Drug Policy and recently edited an IJDP special issue on the triple wave crisis of opioids, heroin, and fentanyl in the US. For over 20 years, Dr. Dan has been actively involved in expanding the use of clinical harm reduction technologies and services, example, naloxone and buprenorphine. He has provided harm reduction-based clinical services at several San Francisco syringe exchanges and was on the board of directors for the San Francisco Homeless Youth Alliance. So with that, Dr. Ciccarone, thank you.
Hi, everyone. My name is Dan Ciccarone. It is a pleasure and an honor to be here. Thank you to DA Harrington for inviting me, for staff and making sure that I got here virtually in one piece. I would much prefer to be there in person, but be it as it may, we're meeting here virtually. Thank you also to members of the community, the Berkshire community, including harm reduction, law enforcement, and service providers, for the conversation that will follow. I look forward to being part of that panel. What I'd like to do is present speedballs and goofballs, stimulants in the fourth wave of the opioid crisis. Here you'll see on the title page my co-authors, if you will, my co-investigators on this project, and I want to give them credit. This work comes out of the Heroin in Transition study. This is now in its 6th year, funded by the National Institute of Drug Abuse, part of the NIH. It's a multi-methodological project, a complicated project involving ethnographic as well as epidemiological and ethnographic research. So we have both a 10,000-foot level of drug use and drug problems that's using large databases, for example, but also we have a 1 foot or a 5 foot view, and that is of street-based drug use in our ethnographic research. And you're going to see a little bit of both of this in this presentation, and of course I will point to our published literature for more. So the drug overdose problem is currently in the form of a triple wave epidemic of deaths due to opioids. Opioids have come in 3 waves of mortality based on the class of opioid that we're talking about. The first wave was due to opioid pills. This is the prescription pill phenomena that's been in the public consciousness and media consciousness for over a decade now. It started in the 1990s and has increased to present. It started to level off, and that's because of our policies related to opioid pill prescribing. Unfortunately, those same policies have begat a heroin epidemic, and that heroin epidemic, the rise in mortality beginning around 2011, has risen to surpass the deaths due to opioid pills, also beginning to level off now, which is good. But the third wave of the epidemic, mortality due to synthetic opioids, including fentanyl, fentanyl analogs, of which there are about 200 different varieties now, and other synthetic non-fentanyl opioids have begun to rise and continue to rise to present. I just checked the latest CDC data. They have provisional data, preliminary data, published as of January 2020. The deaths due to fentanyl continue their rise. In fact, they've accelerated in the last few months up to January 2020. And unfortunately, we're also in a 4th wave now, whereas mortality due to a different drug class, a non-opioid drug class, the stimulants, which include cocaine and psychostimulants such as methamphetamine, have begun to increase in the last few years. The synthetic opioid problem, what we might call the fentanyl problem, or fentanyls problem, is a regional problem. You can think about, if you look at this map, we see that overdose deaths due to fentanyls have been greatest in the Midwest, down to Appalachia, over to the Mid-Atlantic and up through New England. It is beginning to spread, and in this geographic pattern is due to dealing. It's due to where the criminal traffic organizations want to spread fentanyl. The fact that it has not gone to the Western United States has been a decision, if you will, on their part, but that has begun to change. We are seeing fentanyl and fentanyl-related deaths in the West Coast, just not nearly to the degree of the high mortality in the Midwest and Northeast. Looking at a couple other maps, I just want to compare different drug categories and mortality patterns. If we look at the graph on the map on the left, we see the 10 top states according to the DA with deaths due to opioids, including pills, heroin, and fentanyl. And we see that pattern of the Midwest and New England, including Massachusetts. Massachusetts is highlighted there as particularly having a heroin and fentanyl overdose problem. If we look at the map on the right, we see a similar but broader pattern involving cocaine. But interestingly, now put up a map around methamphetamine deaths, and you see one that almost completely overlaps with the opioid mortality pattern, including increasing deaths in New England and especially Massachusetts. The reason why this is important is that it's historically, it's a historic change, right? Methamphetamine, we don't think of methamphetamine as being an East Coast drug. We think it certainly is a West Coast drug extending back into the 1970s, but its penetrance to the East Coast has been rare. Now, cocaine, we know can be common on the East Coast, particularly New England, but not methamphetamine. But yet methamphetamine is on the rise, and we should be aware of that. From a public health and clinical perspective, I'm quite curious about what is driving mortality in the stimulants realm. We don't tend to think of stimulants as being particularly dangerous drugs. Yes, fentanyl is super potent. Yes, heroin causes overdose, acute death due to overdose. But why methamphetamine? So I've been pondering this and have a list of sort of questions to dive into. Could it be changes in supply? Could it be increase in demand? I don't have time to go through all of these, but I'm going to just highlight a few of them as part of my process of investigation. So increases in supply, could it be changes in production or increases in purity or potency? Here we see, according to Customs and Border Protection, the rise in methamphetamine seizures in the southwest border. You might think of seizures as being good law enforcement, and it is, but it also, in drug policy, is just a marker for increased supply. So this to me means that the supply coming into the United States has increased. But we also, and most of that it points to, of course, imported supply, but there is also a rise locally in domestic supply, according to this map from the DEA, increase in the Midwest and particularly states like New York and Pennsylvania, increase in domestic production of methamphetamine. Meth purity and potency have gone up to historic levels. Okay, this graph shows that as of 2018, we've reached an unseen height of 97% potency and 97% purity. This, in a prohibitionist world, right? We should not be seeing drugs of this high quality. This is almost pharmaceutical quality, given a prohibitionist regimen, right? And yet we are, and this is worthy of investigation. Just means the stuff is good. But another question that comes up in terms of driving mortality, is there contamination? So if we think, well, maybe meth isn't so bad all by itself, but what happens if you combine it with, if it's contaminated with fentanyl and people don't have tolerance for a powerful opioid like that? So it becomes a legitimate question. There's been a lot of bantering on Twitter and social media and even in the mainstream media about, you know, this is contaminated, that's contaminated, everything's contaminated. But where are the good studies? Well, proud to say that we did a good study. we took this is unpublished data. We took a large database of criminal justice obtained drug seizures in the state of Ohio. This is over 200,000 drug samples over almost a 10-year period. And what did we find? We analyzed this and found that about 7.5% of cocaine samples were cross-contaminated with either heroin or fentanyl. We have to remember that we're on the East Coast. If it's labeled heroin, it often contains some degree of fentanyl, so it's heroin/fentanyl anytime I say heroin. So here we have a solid figure from one state over a broad period of time showing increases in contamination of cocaine with heroin or fentanyl. For methamphetamine, it's a little bit lower, about 2.5%, but rising over the last few years. A bunch of questions come out of this research. We don't know whether these are meaningful levels. Is 7% a lot? Is it a small amount? Is 2% a lot or a small amount? I don't have purity, so I can't tell you whether these are a level of contamination that one person could even feel. And certainly don't know if it's an overdose level of drug. I also can't tell you whether it's accidental or purposeful. I suspect accidental because what I'm going to present to you next is that use patterns are showing co-use is up, the combination of stimulants and opiates. And if co-use is up, then perhaps folks who are selling the drugs are also co-dealing them. And that would, of course, point to lots of potential for accidental contamination across the drug classes. So let's look at this co-use phenomenon, right? The speedball is a classic phenomenon. It goes back multiple generations. It's the co-use of cocaine and heroin. The cocaine boosts the heroin. It's particularly liked among people who have a high dependency on heroin, who've been using for a number of years to kind of put life back into their drug use, right? It makes sense physiologically, makes sense from a drug culture point of view, and it's well liked. Now the goofball, which is what I learned was the traditional slang for heroin and methamphetamine. This was not well liked. This was not a common practice. This was unusual from a historical point of view because it's physiologically challenging on one hand, or because the methamphetamine has always been the more powerful drug. It would simply push out any effect from heroin. And so if you were to use this combination, you had to be an expert. You had to be somebody who knew what they were doing. Well, because of one published paper and some intrigue that this was happening, that the co-use of methamphetamine and fentanyl was happening, we went and did some ethnographic research in Charleston and Huntington, West Virginia, southern West Virginia. Before I move into that, the photo here shows somebody holding 2 vials of cocaine, those are with the yellow caps, and 2 capsules of a white heroin. 6 years ago, this would have been very unusual to see white heroin, but a lot of the fentanyl salts are white, so this capsule of heroin is quite likely fentanyl. So what did we discover, just very briefly, in our ethnographic work? Also, as of this point, unpublished data. We just did a field trip just before the COVID rules went into effect. Well, we're finding, of course, that methamphetamine is back. It's back big time. It was endemic in southern West Virginia, but now is resurgent. It's less domestic produced methamphetamine, the so-called, what they like to call it, shake and bake down there, and more of this imported stuff. They call it ice. It's less expensive, and a lot of people consider it of higher potency. Now, some people, of course, missed the shake and bake stuff, so we got a mixed impression while we were there. Here's one view of it. I could show you many photos of the variations in it, but it kind of looks like rock salt. I think in Western Mass, you probably are quite familiar with what rock salt looks like, given your winters, but there it is. This combination that I was calling the goofball and what locals call the speedball is back, and it's back big time. Ever since this imported ice came in around 2015 with its higher quality, people have been combining it. They don't use the term goofball. They didn't know what I was talking about when I brought that term up. They call it a speedball. When I questioned them, what do you mean by that speedball? Don't you also have cocaine and heroin combinations? They said, yeah, we call them both speedballs. Those who like meth with their heroin call it a fantastic feel. Those who don't like it complain, as I mentioned before, about that physiological fight between the up forces and the down forces. There's quite a variety of this combination pattern. Some people won't use it. Some people will use it if it's free. Some people will use it regularly, and they may combine it into one shot, which I'll show you in a second, and they may keep them separate by time. For example, I use meth in the morning to go to work. I use heroin to come down and to de-stress at the end of the day. And some people, the bottom bullet says, are using meth regularly to control their heroin and fentanyl use. And this is something that made me scratch my head as a clinician. It's like, we don't really think of methamphetamine as being a treatment or a control force in someone's opiate use. So it's fascinating to hear these things. And just one of many pictures of showing that the complexity of having to combine heroin and fentanyl. Here we see multiple syringes and a little bit of dexterity to make this into a goofball shot. So because this is coming at the tail end, or not even the tail end, I think the fentanyl phenomenon is still going on, because it's coming as a fourth wave in this multi-year, 2-decade phenomenon, I see the meth use as an organic response. That there's something based on individual need, based on sociology, that this can be seen as an organic response. Some of the things that we heard that challenge us from an addiction point of view, from a clinical point of view, is that meth is popularly construed as helping to decrease heroin and fentanyl use. Fascinating. Helping with heroin withdrawal symptoms. Protecting from overdose when used in combination. Now, I know we debated this for many years, that, because we knew back in the 70s, people were using stimulants to try to reverse. Before we had naloxone as a proper, quote, proper reversal agent, people were using stimulants to reverse overdose. I'm hearing it again. Could be disturbing, could be fascinating. I think I just need to do more research. And they actually using it to reverse overdoses. Dr. Andrea Lopez, a good friend of mine, colleague, has a paper coming out soon for an in-treatment sample using speedballs in Oregon, and this is a paper worth reading when it comes out. So just to sum up, in talking about stimulants, I didn't spend a lot of time with cocaine, but I could have very similar phenomena. Supply is up, purity is up, price is down. We know from economics that when drug patterns go in that direction, use is going to go up. Contamination is happening. How meaningful is up for question. Co-use is also happening. The speedball is back. Robust supply and low prices are driving this. And we have to pay attention to those adaptive responses. Is meth substituting for heroin as a way to reduce fentanyl exposure? The point I'd like to make to a harm reduction audience is that fentanyl remains the deadly element. Okay, keep our eyes on the fentanyl. The photo I took in Huntington, West Virginia, Friday the 13th. We have to recall that polydrug use, this is an old mural in Chicago, polydrug use is the norm, okay? It's always been the norm, but we pay attention to it in waves. Well, now is the time to stop paying attention to it again, right? Polydrug use is up and the combinations are interesting and require our attention, whether we're on the clinical side or the harm reduction side or the law enforcement side. My recommendations and again, my appreciations for being able to open up this panel today, but just my humble suggestions. First thing, we don't panic. Moral panic and layering on stigma and shame does not help. It is in fact our biggest enemy to reduce the public health consequences of drug use. The rise in stimulants shows a failure in public policy, that we've been over-focused on single drug classes for far too long, focusing on just the pills, help begat a heroin epidemic, et cetera, et cetera, et cetera. We need a comprehensive solution. We need supply reduction, yes. We also need demand reduction and harm reduction. On the demand reduction side of things, of course, is treatment. We can spend time talking about that. We also need to look at the big picture. We need to have some community resilience, fixing the cracks in society. The drugs fall into the cracks, right? We need to talk about adverse childhood experiences and addressing those so that children don't grow up more vulnerable to drug use. And we need healing in our communities, both social, economic, and spiritual healing. And connecting supply reduction, demand reduction, and harm reduction is this idea of public health, public safety partnerships. I know Massachusetts has pioneered some of these, and I applaud that effort. Crisis response is going to require a large amount of money. There's a $100 billion idea that Josh Katz and I promoted in the New York Times 2 years ago or so. We interviewed a number of experts. How would you spend $100 billion? Okay, here we see a balanced approach of treatment, demand reduction, which would include community redevelopment, harm reduction, and supply reduction. Your Senator, Elizabeth Warren, has promoted a $100 billion bill to address the opioid crisis. It needs to be revisited. Harm reduction, the reason why we are championing harm reduction is because people respond to it. It is person-centric, it is non-judgmental, it builds rapport. People come in, and we know from treatment that being able to engage people is the key thing here, right? Harm reduction engages people where they're at, okay? We need more harm reduction, and we need more programs, whether they're clinical or program-based, that are harm reduction oriented. Of course, we could talk about overdose prevention. We could talk about hepatitis C and HIV prevention. One thing that I want to advance is the notion of surveillance, drug checking and the like, as a way to help understand what's going on in the drug streams. There's overdose prevention. Here's drug checking. Drug checking could be as simple as a $1 fentanyl test strip. If I was a methamphetamine user, I would want to know about that 3% contamination rate, because methamphetamine user typically is not going to want fentanyl in their drug. Fancier forms of testing the lettuce, as I call it, include STIR, spectrometry. This is the Alpha Brooker machine. It's being used in Chicago above board, but also being used in other places underground, because drug users need to know what is in their drug supply. things that we can champion in harm reduction, going slow, staying in control. We like this theme so much that we heard organically from users themselves is how to dilute your shots, how to do smaller shots, how to do slower shots. This is something that harm reduction can champion and help people stay safer. Baltimore's doing it. Here's their Go Slow Fentanyl is Here campaign. And just to end, there's a couple of papers that I talked about today. The heroin transition studies published a lot. I'm quite proud of that. But I did talk about work that I did in Massachusetts. That's the heroin uncertainties paper. Two Stations Tester Shots talks about this Go Slow and partial shot idea. And the idea of drug surveillance writ large, understanding drug supply in a way that matters to public health is highlighted in the last paper. And with that, I'll acknowledge my wonderful ethnographic team. Here we are enjoying a meal in Huntington, West Virginia. And I'd like to thank all of you for your time and attention. I look forward to our conversation.
Thank you, Dr. Ciccarone. And I want to encourage people in the audience to type their questions. You can type it in the chat, or you can type it, there's a particular Q&A box at the bottom. And while people are typing their questions, I do want to just say hello to some special guests, just so that we get a sense of who's in the audience today. In particular, Representative Tricia Farley-Bouvier is here. Just the Chief Justice of the Central Berkshire District Court, Judge Paul Smith. We have Mayor Bernard from the City of North Adams. Representing Linda Tyre from the City of Pittsfield, we have Gina Armstrong, the Health Department Director, and Roberta Dews. We also have Interim Adams Police Chief Troy Bacon, Lanesboro Police Chief Tim Sorrell, North Adams City Councilors Marie Hartman, Ben Lamb, Lisa Blackburn, former North Adams Mayor Dick Alkenbright, Adams Select Board Member Christine Hoyt. We have Chief Juvenile Probation Officer James Hunt, Beckett Select Board Member Michael Lavery, Dr. Michaels from the Breen Center, Al Bianchi from the Berkshire County Sheriff's Office, and we have some folks from the Committee for Public Counsel Services, Jill Sheldon and Alexandra Piaget. So we have a great audience here tonight, and I'm going to jump into some of these questions from the audience. So we have a question from Sal Garazzo. So Sal is from United Cerebral Palsy, and he provides services to people with cognitive disabilities. So Sal says, can you give any insights into the drug problem as it relates to infant mortality in our region? And is it higher in our community? I'm not sure that the doctor would know such specific localized information, but maybe you can take a stab at that, doctor, if you want, or maybe Jennifer can jump in there.
Yeah, I'm afraid I don't have any local data to talk about. Jennifer, do you have any insight?
Thanks. I specifically work with opioids. I don't really think of it being a infant mortality issue with opioids as much as a neonatal abstinence syndrome issue, which medications for opioid use disorder are really the gold standard for treating pregnant women and babies as well. So I don't really know about the mortality, but it's certainly something that I think is worth discussing, especially around issues related to alcohol use more than opioid use disorder. But I don't really have anything on that. The only thing that I can tell you is that I think it was a 2016 Massachusetts, it's like a QIPP report, which means nothing, but nonetheless, I think that Berkshire Medical Center and the Berkshires were in the top 5 hospitals for neonatal abstinence syndrome in the Commonwealth. So that is, something that has been noted, but that of course was 2016. It'd be interesting to see more recent data from the Department of Public Health about this issue. But that's all I can really comment on that.
Thank you, Jennifer. So we have a question from Dr. Claudia Gold. what do you think of increase in stimulant abuse as an unintended consequence of MAT without sufficient attention to ACEs, which is early childhood traumatic experiences, right? Something like that, and building of community resilience?
It's a great question. Thanks for bringing that up. It's something that needs to be investigated. I was just talking to Sam Quinones, the well-known author of Dreamland, and he was in his new book, or his new investigation. The book's not out yet. Into methamphetamine, has uncovered a wide range of stories about people who are going through MAT who are using stimulants at the same time. And so that's an anecdote at this point until he publishes it, or until there's more formal data. We have known historically, in, for example, methadone programs, that people in methadone programs have a population prevalence of cocaine use that's pretty darn high, or higher than people outside of treatment even. So there is something about the combination of stimulants and the medicines that we use to treat opioid use disorder, buprenorphine and methadone, that needs to be reinvestigated. Now, having said that, there may be something that will bother us or shake us up a little bit. I will remind everyone that the treatments that we use for opioid use disorder, and I'll just highlight the two main ones, the two most evidence-based ones, buprenorphine and methadone, reduce mortality, period. They reduce mortality despite other drug use. They reduce mortality in most circumstances and most populations. So it is our gold standard. If there are side effects from it that are untoward or worrisome, we address the side effects. We do not make the buprenorphine or methadone go away, okay? I do believe that buprenorphine particularly has been rolled out in a very aggressive fashion the last 5+ years, 10 years, and appropriately so. If there's quality concerns about those programs, address the quality concerns. Do not put the genie back in the bottle. We need buprenorphine and we need primary care providers to provide it. But with that said, I do think there's attention needs to be paid to any inadvertent dynamics that are going on, what I would call side effects.
So here's a question from Natalie Schwartz. In what ways do our treatment and harm reduction programs for opioid use underserve those who are also using methamphetamine?
Oh, it's a great question. And that's part of the problem, part of the policy failure of focusing on the one drug at a time. Oh, now we're concerned about crack, or now we're concerned about pills, or now we're concerned about, we need to understand that there are multiple constituencies that require and deserve highly compassionate, high evidence-based, high quality treatment. Drug use is highly stigmatized in this society. Drug treatment and drug treatment professionals and drug treatment programs all sit under that layer of stigma, okay? And so I suggest that we lift all boats and don't exclude people who, regardless of drug use, regardless of gender, regardless of race and ethnicity, from drug treatment.
Here's a question. My wife died 20 years ago from an overdose. Because of the shame of it to the family, her death was classified as a heart attack. Do you think the overdose rate is underreported?
Thank you, and my condolences. These are painful events in our lives, and if we ask enough people in our social circle, we will find that overdose has affected society very broadly. You don't have to go very deep into your social circle to find people who have been affected by it. Shame and stigma are the biggest barriers to drug overdose. We are beginning to overcome them because this is a crisis that affects all aspects of society, all socioeconomic strata, all demographic strata, and it's part of our evolution, frankly. Part of our evolution as a more compassionate society will be to understand not only what drives drug use, but how to invite people into care, just like any other disease. If we think about diabetes, diabetes was highly stigmatized when it was first figured out. We accused people of being fat and having poor dietary control. Now we treat it with medication called insulin, called metformin, called other diabetic medications. Same thing with heart disease. We blame people for their smoking habits and said, you did this to yourself. We don't do that anymore. We treat it with high blood pressure meds, cholesterol lowering meds, and gentle encouragement and nicotine replacement therapy for the cigarettes, okay? Same thing will happen with drug use. We will treat it with compassion and understanding and medication and counseling and support in the future. We'll be embarrassed by how we treat the drug use problem in the historical past, which is now. I think I got to the question. Maybe I just got on a soapbox. I'm not sure, but Andrea, restate the question if there's some part of it that I missed.
All right. So there's some of the questions I'm going to just save on when we open it up to the full panel, because I'm really interested to hear everyone's responses. So, but one more question just for Dr. Ciccarone, and that is, with the increase in fentanyl overdoses, is Narcan, naloxone able to treat those overdoses effectively? Do you need multiple doses of Narcan to combat the PK properties of fentanyl, which is longer than heroin?
Yeah, it's a great question. The answer is naloxone works. It works in all situations. In order to balance out the pharmacokinetic and pharmacodynamic properties of fentanyl, it may have to be pushed in higher doses or more frequent dosing. But it has been successful. We also have the issue of time. The response time has to be perhaps a little bit better. And we also have to remember that naloxone is not always is not a standalone thing. Respiratory support is also an important part. A similar question could be asked about treatment, and I just went through the data on this, including conversation with Dr. Sarah Wakeman, a professor at Harvard, who's leading expert in this. Treatment works. Treatment works for fentanyl as it does for other opiate use disorder. Sometimes there's a little bit of finesse. Sometimes there's maybe a slightly higher dose. Sometimes there's a more of a transition period, getting people from fentanyl use onto treatment. But treatment works. So the take-home message is that our treatment for opiate use disorder remains true for fentanyl, and our overdose antagonists remain true. There is research into stronger antagonists or longer-acting antagonists. And those will probably be announced in the next few years, and we'll learn how to use those as well. But thank you all for these questions, and I look forward to the panel discussion.
So thank you. For me, as a non-medical person, learning about being told to prepare my community for a rise in stimulant use, and particularly with methamphetamine, the big concern for me is that there's treatment for opioids, MAT, but not necessarily for methamphetamine and stimulants. So that's a big concern. And I found your presentation, Doctor, to be very empowering, which is why the dope panic part, I think, is the most powerful part of that presentation. And so we wanted to hear from the panelists here that are in our community that are doing harm reduction work, because harm reduction is evidence-based and it does work. And that's, not just folklore, or it's actually something that the doctor can speak to in terms of it being rigorously tested and evidence-based. And for me, I didn't understand necessarily what harm reduction was until I had an opportunity to visit Portugal and to look at the Portuguese approach to substances. And I wanted to bring that information back to our community, because I really feel like it's critical given our overdose death rates are rising. 6% of our population is addicted to opioids. And now with COVID, this conversation seems more important than ever. So we want to hear from the panelists. We're going to have the panelists introduce themselves, talk about their work. They're going to take 2 or 3 minutes and give us an example of how you use harm reduction in your work. So we're going to start with Chris Machino. Did I get that right, Chris? Yes. So
Very
Chris,
well done. Very well done.
thank you.
Hey, everyone. My name is Chris Machino. I am a certified alcohol and drug counselor and am in recovery since June 26, 2015 from being a daily IV heroin user. And I've been asked to talk about how the stigma of drug addiction has affected my life. And to be honest, more of the stigma that I've faced has been due to the criminalization of addiction. In terms of when I was still actively using, just interactions with police officers, to be honest, who, one story specifically that would probably be most impactful, I was pulled over and held on the side of the street for a crime that I didn't commit. Due to my criminal record, which on February 27th, 2014, I was convicted of 23 felony charges, none of which were related to drugs, but all of which were related to drugs, if that makes sense to everybody. And I think it brings in a difficult conversation. But long story short, my interactions with much of society while actively using was, can I see your arms? Crimes that really I didn't commit. And in my history, I was all for being upfront about the things that I did do when finally things caught up with me. And even since then, even in the 5 years, a little over 5 years that I've been in recovery, I've been hired for several positions, given a start date. And once my criminal record was run and inspected, the offer was rescinded. Most of these being companies, treatment facilities that treat substance use disorder, which is an interesting conversation in itself, to be clear. And the common answer, I think because my history of criminal convictions on paper doesn't relate to drugs, it makes it difficult, and it brings in further gray into the conversation that we're having. The common answer usually that I get when I'm given a start date for these positions is I'm very upfront and very transparent about my past, and I tell them that I have a record, and commonly it's, no, that's okay. We hire a lot of people with criminal records, and my response is typically, I don't think you understand. And then they do understand once they see it in front of them. So I think that culturally, addiction is still viewed as a moral issue rather than an illness. Based on my experience, I've had plenty of conversations with people in the helping professions. I had a conversation with an EMT not too long ago, and I'll finish with this. I had a conversation with a local EMT not long ago who knows my history, and he was congratulating me for the changes, because people historically have been very supportive of my recovery. They're very, very positive about the fact that I have found a way out, which isn't the case when I was active. So this guy just informed me, and he had a conversation with me about being called to houses who he had been called to several times for drug overdoses, and making the decision to not use Narcan, because essentially the impression that I got was because they had gotten their chances and they didn't have any left. So I think that right there just sums up my experience too, in that culturally we still often view substance use disorder as a choice, and that people need to deal with the consequences of their choices. That's how it was always framed to me, rather than, hey, I know that you're having a really difficult time. What could I do to help? That wasn't the flavor I've ever really received. And even talking with people today, it's still commonly not the perspective that I get. So thank you guys for having me, and I appreciate y'all being here.
So Chris, I'm going to have a couple of follow-up questions for you after we hear from the rest of the panelists, but you bring up some really important and interesting points that I want to follow up with. Dubois, would you like to introduce yourself and give an example of how you use harm reduction in your work?
Sure, yes. Hi, my name is Dubois Thomas. Good evening, everyone. I am the Neighborhood Revitalization Director for the Central Berkshire affiliate of Habitat for Humanity. And most of my professional career has been focused on community organizing and neighborhood revitalization and kind of improvement of people's kind of inalienable rights around housing and safety. And so harm reduction in my work, so my work right now is focused mainly on the neighborhoods in Pittsfield, the West Side neighborhood in particular, a neighborhood in which perceives itself as having a drug problem, and I think citywide sees that as a concentration of where a lot of the drug activity takes place. And so a lot of my work is engaged with residents around envisioning what solutions to those problems would be. And I feel harm reduction in my work means thinking outside the box around what solutions are for those issues beyond the tools that have been offered to residents up until this point, which is basically call 911. And I don't know what else a mother or a neighbor could do if in terms of what tools are provided to them. And so I feel like harm reduction on a kind of community scale is building up the community's capacities and skills to care for each other and to form a unified front to solve a problem that we know. We talked a lot about what specific drugs people use and the data around what the results are, but those are symptoms of root causes that neighborhoods need to really examine and solve if they're ever going to eradicate issues like this. So yeah, thank you.
Thank you, Dubois. Andy, do you have any of those polls? Do you want to do one of those polls? I don't know if I can. Where's Andy? Oh, here's a poll. Do you know someone with addiction? So this is everybody should be able to see this, I hope, and vote on that while we hear from, we have 3 local service providers with us. Sarah DeJesus. Sarah.
Hi, thank you. My name is Sarah DeJesus. I am the current supervisor for Healthy Steps, which is the harm reduction program within Berkshire Health Systems. We have a couple of programs under that umbrella, but mainly we have a syringe access or needle exchange program where we work primarily with folks that are actively using drugs. And we talk about harm reduction all day long. It's rooted into our work. It's rooted into my life. It makes sense to me. And so to have conversations with people kind of like what Chris was saying, it's really about how can we help you today or in this moment? What do you need this moment to be okay? And that's helpful for people to know that they have control over their healthcare, over their life, over the decisions that they make, instead of being told, you need to go to treatment, you need to stop using. If people are free to make their own choices and make better, healthier choices, it has a domino effect in their own lives and in the community overall. One of the things we started most recently is a Hep C treatment program. So we have high rates of Hep C in Berkshire County among people that are particularly injection drug users. And there are tons of barriers that people experience to get to treatment for Hep C. People have been told that they have to stop using substances for 6 months or more before they can start treatment. People are told they need a primary care doctor. They need a referral from that primary care to see a specialist. A lot of unreachable places for people. And so we were able to eliminate a lot of those barriers. We're working with a great provider in the health systems, getting people treated, which, like I said, has that positive effect on people. They're able to say, like, okay, I can do this on my own. This is beneficial for not only me, but for the community to reduce, the spread of HIV and or Hep C by using clean syringes, by getting this treated in myself. We have people regularly that are thankful that we're there, that tell us, that it's life-changing for them. And like Dr. Dan was saying, you build rapport with people, and they tell us a lot of things that they're not able to tell providers in traditional healthcare, and we're able to help find pathways that work for that particular person, because there are so many different pathways and different avenues work for different people at different times, and it's all about really just being compassionate and meeting people where they're at and what they need in that moment.
Thank you, Sarah. And now we'll hear from our next local service provider, Samantha Kendall.
Hi everyone, my name is Samantha Kendall and I am the Syringe Access Program Manager for Tapestry in North Adams. Very similar to what Sarah just said, pretty much identical programs, just different organizations. I'm just gonna kind of paint a picture of like what a day-to-day looks like at a syringe access program, because there's a lot of stigma against what people think it actually is. So we primarily work with active injection drug users. All of our services are confidential, so we don't really take any identifying information. They come in and give us used syringes and we give them new ones. It's not as cut and dry as a lot of people think. Like they think it's just a quick exchange and that's it. And that's not the case. We have a very honest conversation with them about the drug use. And like Sarah said, building that rapport and that trust with these individuals is so important, or else they won't come back. And harm reduction truly is, to me, is meeting people where they're at. It's their choice at the end of the day, what they're gonna do. And it lessens the consequences for them physically, mentally, emotionally. And at the end of the day, I think it keeps our community safer. On average, I would say we bring in about 10,000 syringes a month at Tapestry in North Adams, which sounds like a lot, but we always give out less and they're always coming back. So it's really, I truly believe, saving lives out there. We also do overdose prevention, which I think is a really important part of the work of harm reduction. So meaning if somebody hasn't used in a while and they express that to us, we will set up a plan with them. Are you going to be using alone? Can you call us? Can we do this for you? Can we check on you? Things like that. If you don't keep individuals alive, they'll never have that chance of treatment that they potentially may want down the road. So I think that's really important to keep in mind. But yeah, that's all I have.
Thank you. And Jennifer.
Hi, everyone. My name is Jennifer Kimball. I'm a principal planner for public health at the Berkshire Regional Planning Commission, and I'm also the coordinator of the Berkshire Opioid Addiction Prevention Collaborative, which is now in its 8th year here in Berkshire County. Happy to be here tonight. I'm not really a direct service provider. You know, public health is really working more within systems and creating environmental changes within these systems to create better health outcomes. And so I think one of the ways that our organization, which I'll call BOPC for short, has embraced harm reduction, I think, you know, as someone who is working in primary prevention, that is preventing addiction from even happening, overdose prevention, tertiary prevention. Early on in our organization, we realized that we really needed to have a harm reduction framework to all the prevention work that we do, and actually all the work that we're doing in the public health program. You know, we do immunizations, clinics, you know, things like that. So we do a lot of prevention work. So early on, we realized that a lot of the overdose, heroin prevention, addiction prevention, the horse had left the barn, so to speak, and Berkshire County was really lacking in any harm reduction services whatsoever. So that is when we started advocating back in 2013, when we were looking actually at hepatitis C rates for the county, that hepatitis C as overdose is completely preventable. What's one of the things that's driving this hepatitis C crisis? Injection drug use. So it seemed very no nonsense and cut and dried. I think I was really removed from the humanity of it all, more on the science end of things. It's like we need syringe access programs. So we started really advocating, and we got the syringe access program in North Adams. Then we did Pittsfield, and just on August 6th, I'm happy to say that we worked with community members in Southern Berkshire County, and the town of Great Barrington has approved syringe access program for Great Barrington. So that's one of the ways that we've been working in a harm reduction framework, and which some people think of as less of a traditional prevention framework. I do not. We also advocate for naloxone access. We add not just first responders or police or fire carrying Narcan, but everyone should have free and easy, no barrier access to Narcan. So that means that, you know, this was before we had a standing order in Massachusetts, which has been around for a while now. I should remind people, you don't need to have insurance. You don't need to have a prescription. You don't need to be abstinent. You can always, always, always get Narcan at Healthy Steps at your pharmacy. There should not be a barrier there for you. And this is one of the ways that we're also working with a harm reduction framework. And I think the biggest thing now is that we expand into other disease prevention and other works that are post-overdose engagement, things like that, that we're working on going forward. One of the biggest things that we're doing is bringing the harm reduction voices, the best voices to the table, which is people with lived experience and people who are actively using to inform the policies and processes that we are engaging in. And they are the experts. They are the ones that should be listened to. And that is, I think, one of the biggest things that we can do in public health is hand over the power to the people who know how to make the best informed decisions for their own health.
Thank you for that, Jennifer. And now my fellow law enforcement officer, Amalio.
Good evening, everyone. Thank you for this wonderful invite. And those are tough acts to follow. So I wish I wasn't going last. So I, from Berkshire County, I grew up here. I have 30 years in some form of emergency response, police, fire, EMS, and a variety of different disciplines. So having been in the community and having seen the changes in what types of medical responses we had, meaning that being on the front line of when this epidemic started coming into Berkshire County, like Jennifer said, the horse was already out of the gate, and then we had a lot of concerning responses in the law enforcement and in the EMS world. So I have a history of, I'm a paramedic and had several years with Northern Berkshire EMS, but the EMS community stays pretty well connected. So we're hearing what's going on, whether it's in the city of Pittsfield or the city of North Adams or in the rural areas as well. But I can understand we were seeing this epidemic come into play, and initially these responses resulted in law enforcement arriving and that stigma of this is an illegal activity that's occurring, and then all of a sudden EMS is trying to get in there and save a life, and they're being proactive in that, and law enforcement, as they were trained to do at that time with the minimal resources that they had, were unsure what to do, and as a result their pathway was to make an arrest or to collect evidence or to go about their work as trained to do. So I have different views on this perspective than a lot of other people. And then EMS will come into this and be very proactive with Narcan. And I think it's a little comical for our society where there's so many people out there that say, boy, this new drug Narcan is really interesting. And, it's not a new drug, but everybody thinks it is because heroin is new. Not new, but obviously the increase that we saw in Berkshire County at that time. But on a personal note in law enforcement, I started feeling a lot of emotion and feeling a lot of stress and anxiety when I was responding to these calls on the ambulance and in the cruiser, because we were limited and we weren't sure what to do, and so many people were arriving, and there was usually a lot of other chaos going on these calls. And as a result, not having worked these overdose at the level that we were at this time, you weren't as comfortable with starting an IV and giving that the naloxone at that time, and then working that airway management, and then the law enforcement presence of it. And it was just a little complicated. And there wasn't the unity in police, fire, and EMS that we see now as well. So as a result of that, it was bothering me. I wrote an essay that went national about heroin and being the hero in someone's life. I really had to take another stance. And then a few years ago, I met Sarah and went to a harm reduction conference, and I was like blown away. Like, what is harm reduction? I don't know what that is after all these years. And I found that the best thing for me to do currently in law enforcement and in EMS was to talk about harm reduction daily. Use it at every opportunity that I could and make it a standard everyday term. And therefore people started asking, well, what's this harm reduction you're talking about all the time? And then talking about needle exchange in a positive manner. I have always said that any needle exchange facility, when they want to have a new needle exchange location, just saying that to the community members is taken very negatively, because I think stigma is the worst thing we're dealing with when it comes to this entire process. And as the doctor said, we'll shame ourselves in the future when we look back at how we're dealing with this today, and we have to make this better. But we made harm reduction a common thing. We understood naloxone and medication treatment therapies a lot better. We understood that needle exchange wasn't, as Samantha said, here's a needle and have a good day, enjoy your high, and we'll talk to you later. There was some type of intervention or support. And again, focusing on educating law enforcement officers of, all right, let's take the legality out of this. Let's have some empathy and some compassion when you arrive at a medical call. And let's make sure that we save this life before we take any other course of action. And to Sarah's point, let's deal with this at the moment that we're dealing with it with that individual. From there, we developed great educational programs for public access for Narcan and a better understanding. And then in the law enforcement arena, many agencies have allowed me to go in and educate them on naloxone use and the airway management, which was a big concern that we saw initially. People were just given Narcan, and we still see that without supporting that airway. So that whole medical side of it. And now we've been very proactive at making sure that law enforcement agencies in our region are carrying Narcan. Fire is carrying Narcan. We see that here in the city of North Adams. Most often, law enforcement's first on the scene of a medical call that comes in as an overdose, and the fire department here doesn't even respond to standard medical calls. But the chief here said, I want my department dispatched to every overdose in the city. So they don't respond to any other medical calls unless there's a delay in ambulance. but they respond to every single overdose that comes in, with the chance that we can put as many people there that have Narcan and have it available to them and be able to save lives. So harm reduction talking, educating. On the law enforcement side, I do get a little comical when I do a class because I relate it to maybe alcohol or caffeine or, you know, whatever other substance that we say, hey, that's okay though. We can drink all we want, or we can, you know, have all the caffeine and coffee that we want, but it has still some effect on the body. So when we're able to make that comparison and then show them that this individual over here is still human and they still have a desire, and then like you said, Christopher, about the choice, it's, you know, at some point that addiction occurs, and, you know, what's going on in this moment? What is the help we can provide you right now? And we understand that there's times where even when you're using, you say to yourself, an individual say to themselves, I really want to stop it, I need some help, but there's that other physical factor to it. So I just continuously outreach to people in emergency response and then try to connect them with the community and just have an empathetic, more sincere response to this, and not a legal, I need handcuffs, I need to incarcerate everybody involved in this process. Thank you.
Thank you, Amalio. You know, Narcan is a critical harm reduction technique. I get all the police reports for unattended deaths in Berkshire County, and seeing the overdose deaths in our community is heartbreaking, and especially knowing that they could potentially be prevented. Jennifer, I'm going to try to share my screen. Let's see if it works. So Jennifer put out the call to local police and fire asking who carries Narcan. So these are the results that she received from the police department. So out of 32 communities in Berkshire County, these 5 police reports reported back to Berkshire Regional Planning that they carry Narcan. Adams, Great Barrington, North Adams, Washington, and Williamstown. So cheers to them, but we need to have more police departments on this list very clearly. So we have some great questions that I'm trying to get to here. So we have a question from Linda Morris Kelly. Do we have any idea what % of crimes in our county are, as Christopher says, not drug related, but completely drug related? We don't have specific data on that. I mean, definitely people who are involved in the criminal justice system will tell you that the vast majority of crime in our community is absolutely drug related. A particular concern in the attorney's office is around you know, people who are addicted can be more easily victimized, can be victims of crime. A point that Dr. Ciccarone, I remember you making during your presentation that I saw in Boston, is about reasons why women in particular might choose to use methamphetamine over opioids, which I'll let you speak to.
Yeah, so not to make any sort of gross generalizations, but methamphetamine is a tool, and so people will use it to maintain alertness. If they're scared for their property or for themselves, it is a drug that provides greater alertness, the ability to stay up at night. Homeless encampments can be, again, avoid generalizations, but they can be dangerous places. It's a survival drug. It's a street survival drug.
So, you know, and this I think goes back to Chris's point, which I had wanted to come back to. When I visited Portugal, I learned about their approach to drug use, which they have decriminalized personal use amounts of all drugs. And I went on a ride along with the police in Portugal, and I asked them, but how do you handle the crime that is associated with substances, with, you know, the need to, you know, get money to purchase drugs? We see a lot of overlap with domestic violence, human trafficking cases that overlap with our drug cases. And the response from the police in Portugal was they don't have those kinds of crime. They have for a long time provided methadone, high quality medical treatment to people, which really has improved their crime situation tremendously. So I'm curious to hear from Chris. I mean, in my office, we absolutely seek not to criminalize substance use disorder, and we're really working on ways to get people into treatment programs. However, when people cross the line and are committing crimes that we feel endanger the community, like breaking into homes, holding up stores, trafficking, we do prosecute those kinds of cases. And I guess I'm curious to hear your perspective on that.
I think it's a great question, and I suppose if I'm being honest, I don't know that I have the answer. I personally, the majority, not the majority, all of my convictions were breaking and entering and related crimes, larceny, receiving stolen property, and I personally don't think that I shouldn't have been held responsible. I don't believe that to be true. And I think that it becomes a difficult conversation when individuals are directly impacted by the crimes committed in the manner that breaking and entering. Individuals are directly affected by my crime in order to get drugs. So I think that it becomes a greater conversation that I certainly, if I'm being honest, don't have the answer to. I think if we're talking harm reduction, though, I didn't speak much to my piece on it, but I think for a multitude of reasons it's successful. Certainly transmission of disease, as someone who used dirty needles for a long time, I did then interact with the rest of society. Like, I wasn't kept in this small cocoon of other people who use drugs. So transmission of disease could go far. Overdose prevention is massive. Like Samantha said, I think that people can't ever get better if they're no longer alive. But I think that one point I just want to mention to you all, and kind of to touch on Dubois' point about the root causes. I think a lot of times we focus so much on drugs themselves and ignore everything else related. And I know that my history with harm reduction as a drug user, my history of walking into a syringe access program as a drug user was probably the most loved and the most compassionate that I had felt in years. And I think it's objective, but it's pretty clear that what we do doesn't work. It's pretty clear that shaming and criminalizing just perpetuates the issue. Like, I don't think that as a society we're willing to accept that, but from my perspective, it's quite clear that that's the reality. So I think that harm reduction in that way, even if we were to talk about like fully expanding to like centers to use and stuff like that, I think it's maybe not less about the safety and the help and the disease prevention that these places offer, the compassion and the connection that they offer, I don't think gets as much credit as it deserves as well. Like, the staff and the people who choose to do harm reduction work treat people who feel immense shame with love. And that goes farther than I can ever put into words in this forum, you know? So I think it's just worth mentioning.
Also, to your point, Chris, I have seen a statistic that people who overdose, the number one system that they have come in contact with is the justice system. And I'm curious to hear from you if perhaps you received a different kind of response from the justice system. Like, how do you think that would have impacted you? How do you think that could impact other people in our community?
I do want to say, I feel like I made some blankety statements earlier that I didn't intend to, but I will say while I was incarcerated in a Massachusetts county jail, I was trained by their staff to, if I witness an overdose, to call the paramedics and say that my friend stopped breathing, to specifically not mention an overdose, just to like make a point to why I blanketed that so much. But I don't know. I think in interactions with law enforcement specifically, if the first question they asked people was, "How could I help you?" that is so far away from the norm. I can't even imagine the impact that it would have on people. Because it's such a shame-free question. It's such a question that comes from concern and acceptance that this person, it doesn't have some type of moral failing, that they probably don't intend to go and harm all of these people, that they just need some help. And I think if that became the cultural norm from law enforcement, certainly, because you guys are the first ones most people interact with. So I think that in that way, you have an ability that most people don't. You have more interaction than most people do. If the first question was, "How can I help?" I think you go from a culture of shame to a culture of compassion, just with that one question.
So Stephanie Wright has a great question. Are there cultural disconnects when persons are seeking medical intervention outside the dominant culture? How are we addressing this in Berkshire County?
Would you like me to answer?
This is for anybody who wants to jump in. Jennifer's back.
I'm back.
So I'll reread. This is Stephanie Wright's question. Are there cultural disconnects when persons are seeking medical intervention outside the dominant culture? How are we addressing this in Berkshire County? Anybody have any thoughts about?
I should just add, I know that you had brought up diversity and inclusion earlier in this forum, Andrea, and I want to add, just for sake, that if this is my experience as a middle-class white man, I can't imagine how deep the disconnect goes for people who aren't as privileged as I am. You know, like if I have been viewed in the way that I have been, if I was a person of color, if I was a woman, I can't even begin to, privilege is invisible to those that have it, you know? I can't even begin to imagine what it looks like for everybody else. So I'll say that.
You know, I think our difficulty with answering this question, I think, demonstrates that we really have a lot of work to do in our community around race, gender, equity, inclusion. Yeah, Amalia.
Thanks. So I think I'm going to just mention this one thing. When we talk about stigma, and we talk about law enforcement a lot, and I think that everybody would expect that somebody that works law enforcement or, you know, as a paramedic to have this view, because obviously we support the arena that we're in, or we wouldn't be in those arenas. So I think stigma works both ways, and I think that we can all be very sincere in recognizing that and saying that as we address these things and they come to the forefront, it's great to recognize them and find a resolve for them, and just know that all of them are not the everyday norm. So when I defend law enforcement for a moment with the stigma of, and Chris, this is not specific to your situations, because I certainly recognize that, based on what you've shared today, and I think I don't know the right word, but I think the community does an injustice for themselves, even their own mental health, when they continuously say that, oh, they did that because of drugs, or they got, I'm even hearing to the point where if you have a major car crash in the middle of the day, somebody says, oh, they must have been high. They must be doing drugs. So, like, we didn't have car crashes in the middle of the day 20 years ago. But so that stigma kind of works both ways. We see that stigma from law enforcement to the active drug user, and then we see that stigma from the incidents that they've had out to law enforcement. And I would just, in a positive, progressive manner, say, as we start to see changes and progression, especially in our own county with, okay, I know it's only 5 law enforcement. I just want to add MCLA Campus Police is also a Narcan carrying law enforcement agency. But let's recognize that and let that come to the forefront as well, while we're still trying to heal the bigger issue that's going on. When we talk about inclusion and seeing these things, I have to say that thank you to people like Samantha and Sarah, that anybody can walk through that door, regardless of color, race, gender, beliefs, and get treatment. And we see that. And in EMS, we see that as well. Like, I think there's a lot of focus on the value of EMS providers and treating people the same across the board. And from a law enforcement perspective, I think we've made some great progress, especially, and I don't know this factually, I can only speak for the agencies that I've worked with, but we have certainly seen, if you look at the city of North Adams and their interaction with individuals that are actively using or during an overdose, I can honestly say I've never seen an arrest. I've never seen an arrest of an active drug user that's overdosing or somebody on scene there without threatening or causing harm to an officer. But I haven't seen an arrest in those situations as we've continued to progress and put new things into our community. One of the things that we all have to accept is that when you have lack of knowledge of something, it becomes a reservation for you to speak about it. So saying something like, what can I do for you right now, is very difficult, because until recently, we didn't know what we could do. If I didn't meet Jennifer Kimball, who said that there's this out there, I wouldn't know what to do. And I didn't, as a law enforcement officer, I only had one option. When you get done with your training, you only have one option. It's in a leather pouch on your belt, and you put handcuffs on, and you don't know what else to do. But Governor Baker and Polito and all the individuals locally, we've made those changes, and we have better options now. And we just need to push those to the forefront and continue to work on those things. Andrew, I think you're muted.
Andrea, not hearing you.
Yeah, it's like I can barely hear you, like your mic is kind of messed up or something. It's like you sound very staticky and tinny and like you're on Neptune.
Just a little bit.
Are you using your computer or your phone? Maybe you can dial in on your phone if that's an option for you. That's what I'm doing instead of the computer.
Okay, how's that?
We got you.
All right. I don't have this fancy microphone that stopped working for some reason. So, okay, so this is a question from Wendy Penner. What does evidence-based prevention mean to you? I'm not talking about overdose prevention, though that is critical, but addiction prevention. This speaks to the work you mentioned about trauma and also other root causes, economic, social, spiritual. What are the personal stories you are hearing?
So I'll just give a quick answer and then listen to the other panelists. So there's increasing evidence and interest in what is it about the fractures of society that cause drugs to fall in them. The best evidence base thus far is for adverse childhood experiences. I did post in the chat one paper that we wrote on addressing root causes, but there's other extensive literature out there. This is where we need to go. We need to figure out how to spend more time, energy on addressing root causes in society, as opposed to trying to stop drug flows. They just keep ballooning into different directions. New drugs come in. Can we make a more resilient society that is resistant to problematic drug use while continuing to use drugs at whatever safe recreational level people want to? Other thoughts from the panelists?
That's a good question. I think when it comes to like personal stories from people who use drugs, they're all very different. And I think there's a lot of stigma around what someone may look like when they use drugs. And I say this very humbly, this could happen to anyone. So it's hard to say like personal stories. When someone comes into our office, sometimes it's groups of family members. Like sometimes this is all somebody may know. This could potentially be their normal. So it's different. Everyone's so individualized, but you know, I just try to put myself in their shoes. Like, how would I want to be treated coming into my office? And that's with a smile, positivity, and that's all you can really do. I think every story is so individualized that it's hard to really pinpoint that question.
Dubois, do you have a response from your community work perspective?
Yeah, I was gonna say less of the narrative from the individual level, but people's narrative of trying to explain the phenomenon of the opioid or the drug problem that we have at hand, and how when people try to identify the root cause, a lot of times it goes to on the Pittsfield, and I think in other towns, the idea of when GE or when a large employer left, they left a huge void, and overnight, all of a sudden, this new economy showed up, right? That's one story. Another one is that the general decay of our social fabric has kind of like allowed for this kind of isolation, and that this is just a symptom of our disconnectedness, right? And that, as the doctor said, water will find its level, drugs will be taken, drugs will be used. It's about identifying like what is most problematic about that, and then mitigating those circumstances. And I think that's kind of what our kind of combined harm reduction approach is about.
So Jennifer Downs has an excellent point that I think needs to be made. I heard it said at an NAACP meeting that opioid use has received a lot of funding and awareness in the area when there has been an unaddressed crack epidemic for generations, with so many of the addicts being poor whites. So it is an interesting point that the community hasn't rallied to address drug usage until it was affecting middle-class whites, including the victims of crimes being middle-class white folks. And I can tell you, when I campaigned for this office, talking to people about the opioid crisis really motivated people to get involved in a district attorney race and to think about the criminal justice system in a way that they hadn't before, because more people in our community are starting to have personal experience because of the opioid crisis. Whereas, people of color have been pushing for criminal justice reform for decades. And now with the opioid crisis, it's really kind of opened that conversation up. So I think that it's incredibly important to acknowledge that point. So we have a question about Narcotics Anonymous. We have a question, somebody's really interested in expanding Narcotics Anonymous. It was my belief and understanding that Narcotics Anonymous was not evidence-based. I'm, curious to hear from the experts.
Go ahead,
go ahead.
Samantha. No, please, Samantha, go ahead.
I'm personally not too familiar with Narcotics Anonymous or NA. I will say in Tapestry's office, we have pamphlets for NA, but I would also like to point out, I don't necessarily hand someone an NA pamphlet when they walk into the office, because that may not be what they're looking for in that moment. If they express to me that they're looking for some type of support group or something like that, that's when I would approach that conversation with someone. But we do have a good connection with the NA office in North Adams specifically.
Someone in the chat, Wendy Penner, just dialed in. There's been some recent evidence showing what I think she said, great. I'll characterize it as good support for 12-step approaches, particularly for alcohol. And I think the evidence is finally coming in that 12-step approaches do work. I do also want to emphasize, though, that the evidence base for medication-assisted treatment that includes buprenorphine, methadone for specifically opiate use disorder, that would include the pills, heroin, fentanyl, and the like, is stronger. It's good evidence. It is the gold standard of treatment right now. Now, then the question comes along is, can you combine the two? The answer is yes. Can we combine medication with social and psychological support? You betcha. And they're going to work better. So the divisions are historic and they need to be overcome, but combination treatment is probably the way to go.
Thank you for that. So here's a question from Joe Adonides. For someone seeking treatment, what are some common barriers in Berkshire County that are little talked about, i.e. transportation, health insurance, lack of facilities, cost, etc.? Sarah, you've been quiet. Do you have anything to say about that?
All of those are barriers that we hear about regularly, in addition to a lack of treatment beds for people, especially getting to detox. If people come in and say, they don't want to use anymore, they want to go to detox, we're able to help them try to find a bed, but more often than not, there's not an open bed for them. And if we don't catch people in that moment, we lose them until the next time, if and when they may be ready to take that step again. So, and I think that a lot of organizations, specifically in Berkshire County, work really well together to address those barriers, transportation, and things like that. And so it's knowing your community, knowing your organizations, and trying to navigate that with people and reduce those barriers.
I think an interesting, another barrier that we have sometimes is when somebody does call and they're looking for a bed, the process from the EMS standard, unless it's changed in the very recent past, is they have to go to the emergency room and then get evaluated first, and then before that admission up to a bed. So, and I know that there's some EMS supervisors and folks on the chat now, so if that's changed recently, but in the very near past, what we found was that EMS would transport to the emergency room, and because that was a requirement, once they were in the emergency room, they're another patient, and that could be 2-3 hours that they're waiting for that medical clearance to go up to their bed. And as a result of that, they just leave. So I know former Mayor Alcombright, always talked about the ability, in these different forums that we've had, to have that medical clearance option right at the facility where your priority based on what you're there for and that treatment modality that you're looking for, that you could go to, you know, McGee or one of those facilities, get that medical clearance right while you're there, and then go to your room or get that evaluation that occurs. Because we see it here, especially in North County, where, you know, we have the satellite facility and we don't have any mental health psych services here. We always have to transport to Pittsfield, and those complications are when we get that individual. We'll get individuals that will come up and call 911 and go up to the North Campus, and as a result of being in the North Campus, once they arrive, then they'll tell us that they did this because they want that clearance to go to some type of other facility, because the wait is so long at the Pittsfield, and no fault of anybody, it's just the dynamics of the emergency room. So that's a big barrier that we're seeing from the field.
I wanted to comment on a couple of things, which is, you know, having this conversation within the context of a pandemic. The pandemic has really created barriers for many of our population to access treatment. Certainly, and has also created some real fear about going into a facility that has several people in it where they could possibly be exposed to a virus. Additionally, the beds have been reduced in Berkshire County during COVID. And also what's being offered for treatment within Berkshire Health Systems, you know, has not really appealed to a lot of people. They weren't allowed to do groups. They, you know, had to do a lot of things like sitting in their room on their phone, like those kind of recovery-based things, which really just, you know, I know doesn't appeal to maybe someone who is really wanting to access recovery, detox and recovery, and have that support of people with like experience to help them along the way. I think the other thing that limits people's ability to access treatment is kind of, in a way, our system's lack of imagination about what treatment can look like for everybody, what individual treatment can look like for everybody. What it looks like for me doesn't look maybe like what you need or what you're able to do right now. You don't want to leave your children. You don't want to leave your pet. You can't leave your job. So what are the options when someone's telling you you have to go to detox and you have to do these things? I think we need more primary care physicians providing treatment opportunities for people. We need treatment on demand and walk-in, and it doesn't always have to be inpatient. And I think we need to really broaden our horizons about what treatment is, and maybe even, you know, like I said, the harm reduction approach on maybe I don't need to be abstinent from everything while I'm in treatment for this one thing. So I think we're limited by our own lack of imagination, and not to mention just the systemic stuff that's in place as well, insurance, stigma, systemic white supremacy, all the things that prevent us from actualizing our truest self and our most healthy selves.
Thank you, Jennifer. And I think that's a phenomenal point, and that's something that I experienced as a defense lawyer, trying to help my clients. You know, people have jobs, they have families to take care of, people want treatment but can't necessarily take a significant amount of time away from their lives in order to get it. And that's something we deal with now, serving victims in my office. So that's a brilliant point. Andy's going to show us the results of the polls, and then we'll close with one final question. Okay, our drug of choice, nicotine. Yeah, nicotine second, but caffeine just takes it away. So that was my choice. And, you know, I think the point of this is to demonstrate, just as was said before, we all use substances. And in the district attorney's office, we say, there but for the grace of God go I. And I certainly have had people in my family that have struggled with addiction. And, you know, that's our approach. Our approach is to treat people as human beings. However, we do continue to, make distinctions between people that are trafficking and are profiting off of drug use and those who are struggling with addiction. And those are difficult choices that we make. And those will, I think, be, those kinds of decisions will be a further discussion. But I want to end on something hopeful. So I'd love to hear some success stories, maybe particularly from Dr. Dan. You know, can you share with us success stories of communities that have, you know, worked together the way that we are to adopt harm reduction throughout the community and have had success?
Oh, I don't want to take up too much time at this late hour, but the success stories abound. This is exactly the kind of response that's required, conversation between community members, between leadership in the community, both on the public policy side and law enforcement and clinicians. You know, this will have a tremendous effect. We need to speak the same language. What I've heard tonight is I've heard talk about love. I've heard talk about tolerance and reducing judgment. I've heard talk about coming together. And this is exactly what communities need to go through, okay? The drug supply is gonna be the drug supply, right? And can we make, just like COVID, it's an imposed phenomenon. It's a large scale, kind of out of our control kind of phenomena. Can we make our society healthier, reduce harms, increase our general sense of well-being through collective effort, okay? The Berkshire area can do this. You have one of the most lovely places in the world to live. And I applaud you for having this forum tonight. And thank you all to our panelists for their great insights and lived experience.
Thank you, Dr. Dan. Thanks for being with us. Thanks for everybody. Dave Conklin makes a great point in the chat. We're talking about the addict, but what help can the families get? I think that is maybe a whole nother topic that we will look to address. So thank you for raising that. Thanks to everybody, and you know, we'll keep the conversation going.
Thank you all very much.
Good night.